can see that we start with some things like we call it as a targeting approach to different specific group of the population. For example, in 1975, we start with low-income cash scheme for the poor people who are below the poverty line. And in 1980, we start with health insurance coverage for the formal sector, which is the civil servant and their dependents. In 1990, we also start with another formal sector health insurance, which is the Social Security scheme through the Social Security Act in 1990. But you can see that for the informal sector, we start with a low-income cash scheme in 1975, and also in 1983 we start community-based health insurance schemes for those who are not the poor or near poor population, and then we expand low-income cash scheme to cover a specific group of the population. For example, the disabled, the elderly, and children aged under 12 in around 1990. And in 1994, we start some things like a pilot to see the public voluntary health insurance scheme, which we got a lot of experience in providing a voluntary health insurance scheme that Joe Cousin already mentioned about the disadvantage and limitation on voluntary health insurance scheme. But from this development, you can see that we try to use targeting approach to many different groups of the population. But from our experience, it's quite interesting that when we start the low-income cash scheme and we have an assessment in 2000, just perhaps around 35% of low-income card holder were genuinely poor, and only 17% of poor household could get the low-income card holder. So this is a problem that we have the problem of leakage and difficulties in identifying a poor household in the low-income card scheme. So when window opportunity was open in 2002, when we have the new government, and the government have the political commitment to provide universal coverage to the entire population in 2002. So we merged some things like fragmented targeting health insurance scheme in many population group to be under universal coverage scheme, which is the tax finance health insurance scheme. That's the Thailand experience. Next one, please. And just this slide show you about the GNI per capita in Thailand, that we implement different type of public health insurance scheme in Thailand, and you can see that it's not just the situation that we are a rich country, but we start a medical welfare scheme or low-income cash scheme in 1975, when our income per capita was only $390 per capita at that time. And if you look at 2002, when we achieved universal coverage, it's just 2 or 3 years after recovery from financial economic crisis in 1997. So I would like to emphasize that to achieve universal coverage is not just the problem of money, but the issue of strong political commitment is an issue as well.
Quickly tell us some of the early results in terms of what happened when you went to tax financing.
Next slide, please. Perhaps I will spend just a few minutes because there's a lot of panelists on this stage. So just a few minutes more. Next slide, please. Yeah. So I would like to emphasize that when we achieve universal coverage, health financing system in Thailand is not just the purely tax finance health insurance scheme, we can say that we use a mixed financing arrangement because for universal health coverage, it is tax finance for 48 million of Thais. This is 100% general tax finance, but for another formal sector employee or social security office or social security scheme, this is a tripartite contributory scheme. We got contribution from employees, employers, and from the government to finance this scheme for 9 million of the Thai population, or around 16% of the entire population. And these three schemes, universal health coverage, civil servant, and social security, they have different provider payment methods and also perhaps a different benefit package. For social security scheme and universal coverage, we use capitation payment to pay healthcare providers for OP visits, and we use DRG with global budget for IP services. And you can see that the capitation rate for universal health coverage and social security was around 25 to 80 US dollar per capita per year in 2010. So this is the characteristic of health insurance financing in Thailand. Next one, please. And when we look at the utilization rate, you can see that there's a significant increase in utilization rate after the third or fourth year of implementation, especially on the OP visit, because I think that this is quite common in the beginning of many health insurance schemes in Thailand as well. When we start a social security scheme in 1990, the first 2 or 3 years utilization not increase too much, but it will start increase perhaps on the 4th or the 5th year when people know their benefits and realize their benefit. So OP visit in Thailand start from perhaps 2.4 visit per capita per year in 2003, and now we reach at a point of 3.4 visit OP visit per capita per year. But when we look at the hospital admission, it's quite slower increase in terms of increasing in hospital admission from 2003 to 2012. Next one, please. And in terms of financial risk protection, we can say that universal coverage policy can reduce the number of households facing catastrophic health spending. When we define catastrophic health spending as out-of-pocket payment exceeding 10% of total consumption expenditure, you can see on the green line, which is an average of percent of household facing catastrophic health spending in Thailand, which is decreased significantly after 2002. And next one, please. And also universal health coverage, which is a tax finance health insurance scheme in Thailand, can protect many Thai households from health impoverishment. As you can see, the number of households falling below the poverty line reduced significantly after 2002 when we implement the policy on universal health coverage. Next one, please. Next one, please. This one is health impoverishment. Next one, please. And this is area of each province that we monitor health impoverishment from the impact of universal health coverage in Thailand. So universal health coverage policy can protect many households in Thailand and is distributed across our province in the country. Next one, please. And when we look at the distribution of government subsidy for health, distribute to different income quintiles, it's quite interesting that poor household in Q1 and Q2 can get more government screen time tend to get less and less from government subsidy from this policy. So this one is very interesting that we can say that universal coverage policy in Thailand is the pro policy in the public policy of the country. Next one, please. And when we look at the financing pattern, it is interesting that when we start universal coverage in 2002, total expenditure in Thailand was still around 3.8 or 3.9 to 4% of GDP of the country since 2002. This is because of the GDP growth of the country, and even though you can look at the total expenditure, which is the each column, it tends to increase every year, but THE as a percent of the GDP still be around 4% of total GDP of the country, and total expenditure per capita in 2001 was around 218 US dollar per capita, and universal coverage or gold card it is around 90 US dollar per capita that we finance this scheme. Next one, please. And we have the exercise to forecast or project what is the sustainability, financial sustainability of this scheme in the future. If we look at as the estimation of the GDP growth and total expenditure growth, we found that until 2025, I think 2025, we still have affordability to provide this scheme using general taxation. So this is just the initial impact assessment that we used after we implemented universal coverage for almost 10 years.